Nick Majerison here. Welcome to TopMedTalk. Today's TopMedTalk is a reflection on the SCA, the Society of Cardiovascular Anesthesiologists. We're going to be looking back at our coverage from last year and, of course, reflecting on the fact that their annual general meeting takes place this weekend. Please don't forget to check out their website, scahq.org, for more details on that. That's scahq.org. Coming up, we're going to be hearing from Brad Cardinal, Assistant Professor of Clinical Anesthesiology at the University of Missouri. Also, we're going to be hearing from Andy Shaw, the outgoing President of the SCA, and Emily Methengall, Vice Chair of Quality and Patient Safety at the UCLA Department of Anesthesiology. But before that, we're going to be listening to a fascinating, in-depth conversation about the ins and outs of organ donation. Julius Bullock joined us for that conversation.
I'm going to get this into context here because, obviously, the fact that there are organs available, to be harvested means that there's sadness on one side of this equation.
Yes.
Which we're going to respect in passing. Is it the fact that there's a lack of willingness of those individuals who stated that they were prepared to donate their organs? Or is it the challenges that we are not up to speed with harvesting their organs that they were hoping would go and help other people when we passed? That's my intention, that's my hope.
Me too.
Yeah.
I believe it's both.
Okay.
I believe we are short in the number of people who have first-person authorization, which is signing your driver's license. In certain states, you can sign it for organ donation. That is first-person authorization. Second, people do not have that talk with their loved one.
Yeah.
Okay.
Husband, wife, mom, dad, whoever their next of kin is, when they get into a tragic accident.
Yes.
And they are unable to consent for themselves anymore.
And for those who are listening who are not in this field, who might be a little bit confused about how this could go wrong, the making sure somebody is willing to donate their organs and making sure they have passed, if you sort of mean, we've got all that under control.
We do. We have consensus on brain death and brain death testing. Started initially in Harvard University, has been edited and changed over the years. Our rules are slightly different than European and Canadian. As I'm Canadian, you're from across the pond. So some are different, but for the most part in the United States, we have consensus for brain death testing.
Disclosure, I've been through this with a close family member recently, and I worked in transplant when I was in critical care, the transplant unit. And so I was very familiar with the process and really understood it. Going into my family who are completely non-medical, there was a lot of challenge because we do have it figured out as clinicians. Do you feel like that we still have a long way to go with families of donors?
We do, and part of the collaboration of the donor ICU is to build a simulation lab with our simulation experts at UAMS to help the organ procurement organization family coordinators work with simulated patients in order to build these skills and hone these skills from experts in their field. Many people don't know this, but I cannot approach a family for donation, regardless of I'm the executive director or I'm have anything to do with organ donation at my hospital. I do not approach any family member. That is the job of the organ procurement organization, and they are the experts in that field.
Yeah.
And remind us again, you mentioned it in passing, a totally successful harvest of somebody who's decided to donate their organs helps how many recipients? How many organs?
So not including eyes and tissue,
okay.
8.
8, wow.
Yeah. 13 if you include eyes, 2, bones, cartilage, tendons, ligaments, skin. So there's the main organs are heart, lungs times 2, kidneys times 2, liver, pancreas, and small bowel.
Wow.
Yeah.
That's so important, isn't it?
It is.
106,000 waiting.
Yes.
Walk us through a little bit how we are optimizing procurement for patients.
So I noticed it when I first moved from Houston to Little Rock. When we would transfer in donors, because we would transfer brain dead donors, they had a pathway that existed, and they would come to UAMS, and I would see how poorly they were resuscitated in the outside hospital. I got involved when the OP, Organ Procurement Organization, asked me to pronounce a patient in the OR who was terminally extubated and went through the non-heart beating or donation after cardiac death pathway. And I said, sure, I'm happy to help, and I helped and got involved. And the more I got involved, the more I realized how poorly they were resuscitated. And this is what led me to bring acumen and organ donors together. I would notice they were behind in fluids. Their hemodynamics were off the charts. They came on pressors when they didn't really need to be. Lab values were astronomically out of whack. The highest sodium I've ever seen is 182.
Wow.
Jeez.
So we can see there's a lot of complex challenges. There's a lot of emotions going on.
Yes.
You, as Desiree said, you've got your loved one now who you've got through that process of we'd like to successfully donate as many organs as possible.
Yes.
But as we said, part of the deal is this is now a dead person.
Correct.
And you're now about to give critical care resources to a dead person in order to try and get as many organs successfully to help the lives of 8, 10, 12, whatever it is. And does that tension come to the forefront sometimes? Do people say, well, hang on a second, you can't use that, you can't prioritize the use of that bed for a dead person?
It has.
Okay.
And that is the rationale behind me creating an actual unit, the donor ICU, that
Gotcha.
will take the patient away from a trauma,
Brilliant
neurosurgical,
idea.
neuro ICU, and bring it to a separate unit where people who are dedicated to taking care of those patients.
Yes.
Right? We need to remember that those patients, although, as you said, they have passed, their organs will help other people potentially not perish from their disease process. End-stage liver disease, end-stage renal disease, heart failure, lung failure, COVID, lungs. These people have been getting lung transplants. So we change our focus.
Yeah.
And we focus on optimization of the patient, therefore the organ.
And the physiology of the brain-dead human being is very challenging because the brain does a lot of cross-communicating. So now it's super specialized critical care, whether you were saying some of the very high numbers you were reporting.
Yeah, we have protocols. I have protocols for both the hemisphere, management of brain-dead donors, management of non-heart beating or DCD donors, depending on their injury, whether it's a cardiac injury or another type of trauma that they had. Usually our DCDs are strokes, bad head injuries from MVCs, motorcycle accidents, and so on. And so we resuscitate them. And there are protocols that have come from both. I have tried to bring together the protocols from across the pond in the UK, from my home country, Canada, and what was available in the United States, and try to make a protocol that we have instituted at UAMS.
So talk us through a little bit of what it is like to manage these patients.
So when they come in from an outside hospital as a transfer through our pathway, depending on what their injury was from the outside hospital, we'll just give you a very straightforward intracerebral head bleed from a ruptured aneurysm. So that whole brain death physiology, vasodilatation, either Cushing reflex in the beginning. I don't know where they are in this whole reflex arc, whether they're in the autonomic storm or have they passed that and are we now just vasodilated? Coming from the outside hospital, I don't know.
Yeah.
I know the time of their injury, what their injury was, and usually the transferring coordinator calls me and gives me some vital signs. So it'll be something like this. Blood pressure, 180 on 100, patients on Neo, Levo, Vaso, has 2 IVs, no central line, no A line. I said, okay, good, right. So I go back for the day, what's their in and out, give me some other criteria. They give it to me, what's their hemoglobin. You know, I've had hemoglobin as high as 20, crits in the 40s and 50s, because they're this dry.
That would say they're that dry, right?
So in flying terms, you're in a sort of flat spin.
Yes.
Yeah. So you don't know which way's up, down, sideways. You've got to stabilize.
Yeah.
And the only way to get that is to get some reference points.
Correct. And the coordinators that I work with at Aurora are very good about giving me my basic labs and basic numbers, and then we go from there. Usually what will happen, I'll tell you, they've been getting 3% saline, they've been trying to help with brain swelling. So we stop and we reverse that. Off the 3%, I usually give them a bolus. If it's been a traumatic MVC and they've had some type of craniectomy, craniotomy, EVD placed, I may give blood. I do give all my donors blood, both blood and FFP. I maintain a hemoglobin greater than 9 at minimum, and I will use FFP for volume just like we do in trauma.
Because our objective now is that let's focus on the kidneys, for example, because in the hierarchy of preservation of organs. The brain is at the top, but now we've accepted the fact that that's not a priority. The heart and lung are at the center of things.
Yep.
But it's those other organs that, the pancreas, for example, and the kidneys, that are much harder to get that balance right.
Yes.
Okay.
That microcirculation that you talked about many times, I've heard your lectures, that is what I need to fix, and quickly.
Okay.
And so we resuscitate, we get them off their pressors, and it's pretty miraculous. They come, their SVV's 25, their cardiac output's 10. You can see the hyperdynamic patient who is brain dead. Yes, I understand. We work with stressed and unstressed volume, making sure that we get enough preload, afterload, contractility. We hold on any other testing. I don't let them echo the patient. We wait 24 to 36 hours until I'm off my pressors, until I'm resuscitated, until I see the SVV back down, until I see that cardiac output start to come down, heart rate, cardiac index, so on.
As you can hear, it's a frank and engaging conversation. I highly recommend you check out the full episode. The link is in the show notes. We couldn't leave it without, of course, reflecting upon the enormous positive benefit of the outcomes which can be seen with your own eyes. Have a listen to how the conversation concludes.
We do some things that they do across the pond in England. I feed all my donors. So we do tube feeding on all of our donors. They're fed up until the end. If they're not being fed on transfer, we start feeding. We
get a better, happier organ.
Yeah.
We get a happier organ. We know the gut is responsible for so many things.
Yes.
We want that microcirculation to wake back up as we resuscitate those patients. We use thyroid, we use steroids, so on and so forth. So I know that a lot of the outcomes, reperfusion injury is big, liver transplantation. Doing these protocols and things that we've instituted, I've spoken to the transplant surgeons who procured, and patients have done fantastic, even our own.
Yes.
We had a fulminant failure patient whose MELD was 42, calculated the day of surgery. We used one of our organs, was a DCD. The next day, by noon, the patient was sitting up eating. We actually extubated the patient on the table, post-transplant. Everything went fantastic. So we're seeing the effects, the downstream effect on the recipient as well.
That's incredible.
Brad Cardinal now with a conversation about goal-directed fluid therapy. He and Monty Mython get into the weeds with this. It's a fascinating piece, and of course, the fuller conversation is available in the original podcast. Have a listen.
So we all spoke, and I think there was general agreement about the continuum of care that we aspire to. The fact that we targeted our monitoring to the patient's needs. So there was a sort of base monitoring that is for an institution, and then moving up through all the bells and whistles. But the real challenge we got into discussing was protocolization versus individualization, and how that mixes in with the transition into the intensive care unit with the variability you've discussed.
Yeah.
And you gave us two reflections there, Brad, if you could repackage them for us. Your attitude to what's going on in the OR, and then the challenges in the intensive care unit.
Yeah, so we were talking about goal-directed fluid therapy and using the advanced monitors in the OR, and the question was posed, do we have protocols in place for these patients? And kind of what we talked about, what I talked about is that I think it's going to be very hard to get a protocolized approach in the OR because it's a very dynamic environment. I also think that as cardiac anesthesiologists or anesthesiologists and cardiac surgeons, we tend to be a little bit more arrogant to say that we don't need protocols in place, right? So that we have all the technology there with looking at the right heart, the TE, the advanced monitors. And so it'd be very hard to follow a full protocol. I think we have the information there that we know we need to fill the heart with preload, and we have the parameters to be based off of that. And then we go to contractility and afterload. And I think we know to do that. I think when we go to the ICU, we need to give a standardized protocol, a little bit of approach, because the intensivist, the cardiac surgeon, the anesthetist, the anesthesiologist, whoever it is that's supervising the care in that unit is not at the bedside 24 hours a day, right? But the bedside nurse is. And we need to get that information to them and give them at least a similar set of objective data that we have in the OR to the nurses that are caring for the patients. And I think we can do that through some of these advanced hemodynamic monitors. We can still provide individualized care even with those protocols. So the individualized care can come in when Monty comes by does a transthoracic echo, sees that the heart is contractility is measuring well on the echo, look at the DPDT, it's 500-600 on the monitor, and know that that's our goal for the day. Or that, maybe we are on high dose vasopressors and the SVR is running 1300, but our goal is to kind of titrate those vasopressors off today. So we're going to change the goal to 1000 for the patient for that day. And so it gives the clinician, the clinician the ability to individualize the care, but it also gives the nurse the objective data and the empowerment also to help make those decisions based off objective data. And these are dynamic patients, so they don't always follow an algorithm, and we all understand that. Yeah, they forgot to read the book.
Yeah, the text.
But if they follow the algorithm, or if the patient doesn't follow the algorithm, it also gives them the ability and the empower to say, I need the physician, the clinician at the bedside to evaluate this patient because we're not in the algorithm we should be in, and there may be something else going on with the patient.
Do you find that people adapt to the algorithm quite quickly? Because the physiology is the same. It's preload, afterload, contractility. But you're sometimes throwing some new numbers at them, like the DPDT and the EA-dyne and those things. I think everyone gets cardiac output, cardiac index, stroke volume, heart rate.
Right.
Do they adapt fairly quickly? Because it all looks a bit complicated.
The alphabet soup.
Yeah, I think it can be, right? And you're also almost getting at a culture change with it as well, which is not easy anywhere, whether it's in the OR, before the OR, after the OR, in the ICU. So I think what helped us and what can help everybody implement this is let the people that are using it, the bedside users, develop the protocol themselves, right? It doesn't matter kind of what protocol you use at first. If you have something that's standardized, that makes physiological sense, then you can use that for a while, right? Know where the problems may lie or where it needs change, and then change it. So we're probably on our 4th rendition of the ICU protocol. And what we found is we kind of simplified it more and more each time to help with that. But it still isn't just putting something up there, having the monitor tell you information, and then it's fixed, right? Yeah. So you have to be able to interpret that information, know that it's actually quality information, right? This monitor isn't going to give you good information out if you put bad information in. So you need to know the basics to know that the arterial line is working properly, and that you're connected properly, and those type of things. So interpreting the information, knowing that it's reliable, and then intervening on the information as well, right? If we talk about HPR, the hypertensive predictive index, it can alarm all day, and it's not going to change the patient's outcome, right, if you don't intervene on it to prevent that hypotension.
What are the benefits of the SCA and their annual general meeting? Emily Methengall gets into it with Desiree Chappell and Monty Mython.
The SCA is one of my favorite organizations. I've actually been involved with it since I graduated as a fellow in 2013. Been part of the problem-based learning discussions, have given some lectures, was part of the workshops. A couple of years ago, was asked to join the scientific program committee, so had a hand in creating the program for the 2018 meeting and the 2020 meeting, which got canceled. And then the virtual 21 meeting, and then this meeting. So it's been a really, really great experience. And other than that, have made so many good connections. And the SCA got to connect with a bunch of women here, helped found the Women in Cardiothoracic Anesthesia Special Interest Group in 2018, which was just a hodgepodge group of women that came together who were kind of focused on growing leadership in women in the SCA. And we've grown significantly since 2018. We're a big group now in 2022.
I went past your special interest group meeting last night. It was busting at the seams. It sounded like a party.
It really was. There were over 100 people there. We were very, very happy.
Yeah.
And then in 2020, got elected as an early career director of the board. So I've been on the board of directors for the past 2 years. And it's been really exciting to be a part of the board and getting to know like Andy Shaw and Chris Troyanos and all these amazing SCA leaders. It's been really great.
Yeah. So Emily, if you look back to your first meeting, how long ago did you say that was? It's always rude to discuss.
2013 was probably my first meeting.
So we're going back 9 years ago.
9 years ago.
Have you seen quite a transition in, I know you've been part of forming it, in the program, the contents? In 2013, were we all about discussing physiology and the heart and methods and mediators? And have we transitioned to a different world? I know that's still important. But,
yes. I would say 100% yes. I would say in 2013, a lot of focus on kind of the science, the basic physiology, anatomy, echo. We still have that kind of focus here at the SCA, but I think there are more practical things that we talk about. I mean, the lecture this morning about professionalism in the operating room, that would have not been a lecture in a 2013 SCA.
Wouldn't have been allowed.
No.
Maybe not. Yeah.
There's a problem.
But I think there's this increasing recognition of kind of the communication problems that we have, not just in the cardiac surgical operating room, but, in anesthesia and in operating rooms in general. This year was the first year we had a professional development workshop, actually focused on kind of early and mid-career faculty, helping them work out, issues with negotiation, leadership skills, creating their elevator pitches. That's not something we would have seen in a previous SCA. So I think the SC has moved really, really far in creating really great content for its members.
We discussed the international approach of the SCA with Andy Shaw last year. Have a listen to why they're so committed to getting a global perspective on health.
I have really noticed a major international presence at this meeting this year.
Well, thank you. And I'm glad you have, because that's not a coincidence. I'll point out that we don't have any geography in our name.
Yeah.
Yes, it's true. We have historically been a North America, US and Canada focused society. Nevertheless, we have very strong links both with our European colleagues and Far Eastern colleagues.
Yeah. Australian, I've seen that.
Yeah, there's Aussies here. There's a couple of Kiwis. We have folks from Europe. This is even despite the current travel situation. Yeah. Online, we have about 190 or so people from around the world logging in to join the live streams, which is exciting. The reason it's important to me is it's one of my 3 presidential priorities for my 2 years. And this is exactly halfway through my particular presidency. But international outreach, international collaboration is important to me. I've worked in 3 different countries and have seen that although, culture, compensation, reimbursement may be different, the patients have the same diseases, they have the same problems. Yeah. And in essence, because we're all people, we tend to be fairly similar around the world. And so, yes, the tools we have are slightly different and we pay for things slightly differently. But fundamentally, doctors, nurses go to work to do the right thing for their patient. That's universal. Yeah. And so one of the things I wanted to do was to extend our arms around the world, if you will, to try and make contact, to learn from our partners in China or Korea or Japan or Germany or South Africa or Brazil, anywhere, and see what we can learn from our colleagues around the world, and perhaps we may have something to offer in return. Yeah. And it's been really rewarding to me to see how much enthusiasm there is for this. Mm-hmm. Yes, there's skepticism. Yes, people are concerned. They initially they think, well, what's the SCA doing? Why aren't they just North America? And so I've spent a lot of time on the phone with, my co-presidents around the world saying, this is such a good idea. We need to get past whatever the anxieties are. Yeah. And of course, the anxieties are, well, if you form a new, as we have, International Academy of Cardiac Anesthesiology, why would my members want to be involved in that? And the answer that we tell them is opportunity, educational, research collaboration. Yes. And so because of that, we've made the new academy can only join through your local society. So now that becomes a reason to join your local society. Yeah. And so international partnerships, very important to me. And I'm glad that seems to be, starting to gain some traction.
Andy Shaw there explaining why a global perspective on health can be so empowering and useful for practitioners on a local level. Thanks for downloading TopMedTalk. Don't forget to subscribe and, of course, check us out on social media. We've even got our own YouTube channel now, which is picking up a fair few listens. And we're, of course, on Twitter and Facebook and Instagram and LinkedIn and all the rest of it. Also, don't forget to check out the show notes for the fuller versions of these conversations, which we've clipped for you in this week's podcast.